I am Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. We have another wonderful panel for us on tonight related to cementless knees, and we're going to talk about cemented knees as well. A topic that if you've been in orthopedics for a long time, you would have certainly have been involved in this argument, this discussion, this controversy for 20, 30 years. Some things have changed in recent years. I want to comment that we have a wonderful panel, and I'm going to start by asking them to introduce themselves. Khalid, you want to start us off, please?
Sure thing, Ira. Thanks. My name is Khalid Yousuf. I'm in Dallas, Texas, part of the Baylor Health System, and I'm excited to be here, join these great guys on the call, and really shares us some experience with cementless technologies and how I use that to help my patients.
Excellent. Roshan Shah, Dr. Shah.
Yeah, thanks for having me, Ira. This is Roshan Shah. I'm in New York at Columbia University. Uh, I think the whole platform that you've created here is fantastic. So I'm excited to be a part of one of these sessions. And the panel is fantastic. So all good things.
That's great. Colin, are you on? Colin Wood?
Hello. Hi, everyone. Excited to be here. My name is Colin Woon. I'm in New York. I'm part of the SUNY Downstate group. I operate out of a few hospitals in Brooklyn. I'm the director for arthroplasty at One Brooklyn Health, Wyckoff Hospital. I'm also in the Bronx at Lincoln. So a few hospitals. Yeah, I love cementless knees. So let's talk about it.
All right. And Atul Kamath?
Thanks, Ira. I'm a hip and knee surgeon at Cleveland Clinic in Cleveland, Ohio. Sounds like I'm a repeat offender here or repeat guest. Past topic was on AI and orthopedics, so something you can't put your hands on and feel and touch. And now we got cementless knees. So excited to chat with this STEAM panel and Ira and kind of look at the evolution and then controversies and other kind of things. So it's going to be a neat evening here. So thanks for having me again.
That's great. So let's start. I'll start with Colin, and I'll start with a why question. Why do you recommend what you do to others, specifically cementless knees? Why do you recommend it? What's your why behind cementless knees? Oh, you're on mute, Colin.
Yeah, there's the book answer and there's why I do it. So the book answer is, all the indications and all the different patient populations, which we'll go into. But the truth of it is, logistically, cementless knees are a delight because if you've worked in an OR, so if you have a very efficient team, and at some hospitals that I go to, yes, you hold your hand out, they give you the next instrument. When you go, okay, open the cement, they go, okay, we have one in the warmer, one cold, so we're going to do a one-on-one mix. We're going to do this, and then it's a breeze. But if you're at a place where, oh, guess what, your tech's out, or you have someone who doesn't really do a lot of orthopedics, and the cement part, so the momentum of the case grinds to a halt when you start hitting the cement part. So logistically, cementless knees are just a nice a way to get around a knee replacement, have great results, and yet have excellent flow in the OR. So for the personal reason, my reason, it's just a delight to do. It's a lot more efficient. Yeah.
Atul, what are your feelings about this?
Yeah, so I agree with a lot what Colin said. I think we're all kind of chasing, now with second generation plus cementless implants. I think we're chasing fixation, right? Like we did on the hip side. Osteo integration, I think, is the key here. I think it's the most exciting part of it. Like if I can get an implant to seal into that interface, I think we have obviously younger patients, we have more obese patients, we have more active patients. I think we're looking for that interface and that implant that's going to be kind of the next generation. So I think we're always chasing. I think we're evolving. I think we have some great implants. But I think it's also, Colin brought up the efficiency piece. Yes, it's nicer from an efficiency standpoint. And again, but again, for me, the most attractive right now is kind of finding that ultimate interface for fixation.
Right, that's right. Khalid, your thoughts on why you're a big cementless user?
Yeah, echoing all the previously made comments, and I'm chasing that forever, knee. So for me, it's all about fixation, and our patients are getting younger, and so the idea that, hey, I want something that's going to last them as long as hopefully their life, and I don't think a cemented knee can do that for me. I think size of patient matters, and in general, obesity is a problem, but definitely here in Texas, we see just larger, sometimes not obese men or morbid obesity, but it's just large, muscular, 280-pound guys, and is cement the fixation that will hold up with time, and I don't think it will. So that's where cementless comes in for me.
Roshan, what's your preferred technique now, and who are you using it on, and your feelings about current modern cementless?
Yeah, Ira, the long-term biologic fixation is key. And so if I were dating cementless knees, I'd probably have the most, complicated relationship with them. I've gone from all in. I was an early adopter of one of the models in 2019, and then went to never. And then I've just fluctuated back and forth. I think technique is 100% the key to making this work and to making it successful. I don't know that I have the best technique for it, which is why I don't use it in everybody anymore. I haven't seen a whole lot of failures with it in that early period, but there were a couple, and some weird complaints at like 6 months that I didn't quite understand. And I think so. Let me first go with what technique doesn't work. I use a lot of laminar spreaders, which damages that bone cut. And I think if you can preserve the surface and it's nice and planar on the tibia, you have so much more success. Same thing with the femur. And on the patella, same thing, a nice planar surface. So for me, it's robotics when I do use it to ensure that I've got a really good quality cut. There's no jiggle of my hand or too much coffee that day that changes that planar tibial surface. On the femoral side, it's really if my trial fits down well from the same thing, a good quality cut, then I think the cementless is a no-brainer. But the tibial side is the one that gives me pause, and the reason I don't use it on everybody. On the patella side, actually, I mean, I early on I had to take out a couple for infection, and just did not have. I'd be curious to see if anybody has a good technique on how to take them out, because I really lost a lot of patella bone, and at that point decided I would not put in any cementless patella.
Right. So you're cementing your patella. Let's talk about the patella for a second, because that is a cause of a lot of controversy. Atul, what's your feeling about cementless patella? Maybe you don't use a patella implant at all. I mean, what's your approach?
Yeah, great question. Thanks for giving me the hard one here.
Yeah.
So the patella, I think, there's a big debate even in cemented knees, right? Resurfacing or not. I've gone to in general being a more of a non or selective resurfacer, regardless of implant. Now, I think Roshan brings up a great point. We've had some challenging implants. I think certainly the bone preparation is critical there. I think also from the standpoint of cementless fixation, there's different varieties, and there's some ones that are a bit more tried and true. So, I'm not all in or all cementless fixation on the patella. And again, it's usually unresurfaced patella in my kind of kinematic kind of alignment philosophy. But I will cement here and there. But again, it's more non-resurfacing and just in general. But that goes back to my philosophy of just the patella non-resurfacing or selectively.
Interesting. Colin, your feelings about the patella now? You have big experience.
Yeah, I want to touch real quick on techniques though, right? One of the
Okay.
techniques concepts is like Roshan said, what doesn't work, I think, like using intramedullary alignment guides or cutting guides for like the tibia, that wouldn't work. You don't want to violate the guide, the tibia at all from that standpoint. I also think coupling your femoral cuts with the 4-in-1 cutter matters a lot. So I'm not a robotics guy. I'm doing it with manual technique or with pinless navigation. And so for me, having a coupled 4-in-1 cutter, making sure all my femoral cuts are coupled makes for good cuts and good contact.
Describe that for me, that 4-in-1 cutter.
Yeah, so just the four any it's not open capture. What do they call it? Actually, I'm losing my words here. It's not a it's just a standard 4-in-1 cut.
Right.
You want that. So you want that all to be coupled. And if it's not coupled, then you could have some toggle and then your cuts aren't going to be match up to the femoral component.
Right.
That
Yeah,
makes sense. Someone help me out with that.
Yeah, to echo that point too, I agree with Khalid. For example, I'm biased. I've developed robotic systems, but robotics in and of itself is not. We try it. It's often mated with cementless implants in the industry as well as in kind of philosophy. But I mean, robotics, in terms of there could be deflection of the saw blade, there can be different sclerotic aspects of the bone. So I think even with using robotics or not, I think to Khalid's point, if you have a great mating of that implant with the cutting trials, you can have great press fit, so to speak, or interference fit. So
Are
And then,
looks like
and then
ahead.
having good saw blades, right? So I think that's a big point. So I use fresh saw blades for my femur. It's a different saw blade for my patella. It's a different saw blade for my tibia. I want the best tool at that time to make that cut. So you don't have deflection or dull edges from that standpoint.
Absolutely critical point. When I went all in on cementless, new saw blades made a huge, huge difference. It's really remarkable how quickly the current version of saw blades are dulling. You get one or two cuts out of it. So that's a really good point.
I actually got even deeper and I started looking at striker blades versus brasseler blades, and then looking at the cost of it for my system. The brasseler blades happen to be my preferred blade, and they've got open channels so that the heat hopefully isn't as high and you don't get that bone necrosis and thermal necrosis. Just thoughts on that. It's also a good way to deflect the patella question by just diving into a different concept.
Strong work, guys. Strong work. I won't bring up the P word again. All right. Let's talk a little bit about expanding indications. I've been in this game a long time, and all of a sudden, I am purchasing total knee replacements for X amount of dollars as cemented, and now there is it must be a virus carried by a fellowship trained orthopedic surgeon who goes into town, and all of a sudden, because I'm seeing viral increase in cementless technology in knees. It's just some people. I mean, Antonia Chan wrote an article for JOEI and talked about 70% of her knees now are cementless. And so, where do you think that's coming from, and what explains some of and are there more expanded indications, or is the indication just knee arthritis? Who wants to take that on? Get
I'll
going.
take it.
Okay, Colin?
Yeah, so I think we're circling back to the question about who is a good candidate for cementless knees. And historically, we always talk about the young patients, the active patients, the obese patients. So it's been that group, we are seeing more and more patients who are younger and have advanced arthritis and need knee replacement. So these patients ideal because they will outlive the lifespan of a cemented knee. So we're not going to see, we hope not to see osteolysis, loosening, aseptic loosening, all that in the young patients who will live for a long time. And then the active patients, these are young patients or chronologically older, but physiologically younger who do, I have people who are still running actively. These are half marathoners. These are triathletes. They want to still be able to do what they used to do. And you don't want stress shielding. In these patients, you want to be able to transfer load immediately from the load-bearing surface down to the bone. And a biological fixation, which we talked about, it's more than capable of doing that. And then finally, the obese patients. In Texas, in Brooklyn, we have so many obese patients, and they are not getting thinner. They're getting more and more obese, and these patients need knees, and they're younger because, just because of the natural history of the disease. So they get the knees, and traditionally we've been putting stubbies, we've been using cement, but at the end of the day, they still fail. And the cementless knees allow us to bypass that. I think we are also expanding indications into traditionally what has not been thought to be good for cementless knees, including the rheumatoids, inflammatory arthritis, the AVNs with sclerotic bone or cysts. So it's these expanded indications. So I think the trajectory of cementless knees is going to follow the trajectory of the cemented stem, the hips. We started off with cemented cups with cemented stems, and then we went hybrid with press fit cups and cemented stems, and then now everything up there is cementless, excuse me. And I think the same will happen with knees. We are seeing the onset of the cementless primary knee. We eventually will see in the United States, I know it exists in Europe, the cementless uni, and there are now custom implants that are cementless revision implants with trabecular metal sleeve/cone hybrids as well. So I think that the tendency is to stray away from cement. So one of my teachers a long time ago used to say, cement is for the driveway. It's not for knee replacements. And he was someone who firmly believed in the 4-screw base plate. And another teacher, Chit Ranawat, he used to say, back in the day, he used to say that the press fit tibia is not ready for prime time. So that was something he used to stress to the residents and the fellows. The cementless press fit tibia is not ready for prime time. But I think now that we have the technology, we have the ability to flip the base plate over, do additive manufacturing, add 3D printed titanium ore onto the backside surface. I think we are able to do that. And I think you touched on the saw blade as well. So the stiffness of the saw is something which we've looked at as well, because you want a flat cut. You don't want to recut, and we're slowly refining our techniques. It started off with Makos and robots, and only robots get cementless knees because we think, hey, the robot can do a great job. And true enough, the robot base plate is the robot saw is a 2mm saw. It's a lot thicker than the ones we use with the traditional captured guides. But I think the general public is slowly moving away from that. So the fear of not having a completely smooth surface just because you don't have a robot, I think we're moving away from that. We've shown that even with manual captured guides and saw blades which are thinner, the 1.27s, for example, we can still achieve the same results, same flat surfaces which we need. So I think, excuse me.
No, interesting. Go ahead.
Yeah. So it started off with, hey, we have to have flat surfaces because we don't have cement to bail us out with the defects, the divots, the bumps. We don't have cement to bail us out. Then we moved into, okay, now we have robots, so let's put cementless base plates. And then we moved into, now we use thicker saw blades that don't have as much play and wobble, and we make cuts, single cuts, no recuts with those. And then I think we're slowly moving into, okay, if we have a little bit of a defect, what are we going to do then? If we have a little bit of a defect, can we bone graft it? If we have a bit of a bump, can we tamp it down with a bone tamp to make that flat? Can we use the different tools to rasp it out? So I think we're moving into the area of where this is more of an art than a science, because you're trying to make a smooth surface. So it's almost like bone has become putty in our hands. It used to be something we were afraid of. You have to have it flat and then put cement on it. And then now I think we are moving towards trying to mold the bone to fit the base plate. And there are many ways to do that, besides the saw, I think. So it's the fear. We're moving away from the fear of the unflat surface. That's what we have. And of course, the technology is advancing to give us that 3D print, which we didn't used to have where there used to be screws, now we have pegs, we have keels, we have stemmable keels, stemmable, extendable stems. So all that technology is rapidly advancing because we need it, and the industry is hearing this, and they're producing it for us.
There's a question from the audience. Yair Kissen's here. Hi, Yair. How are you doing? Are you still around?
Good. Thank you. Yeah, thanks for having
Yeah,
me.
you had a question about.
Is it a game time decision? It is for me. Like if it's hot knife through butter, feel through the bone, then I'm not going to do cementless. But what do you guys think about, osteoporosis? When do you kind of say it's too much, or do you ever look at the patient's DEXA scan? I'm not sure if I would know what I was looking at, but if you ever do, to decide.
Yeah, that's a
Yeah,
great
how are you? Oh, sorry, Atul.
jump in.
Just very briefly, I definitely do not look at DEXA scans or order them, but for me, I'll call for the tray when making the bone cuts because it's a game time decision. And it's just with the feedback I get from the saw blade is when I'll know if I can try to go cementless.
Yeah. Any Atul?
Yeah, no, I think I'm not 70% of cementless as you mentioned before with some folks, but I it's increasing, but it's still about 40-50%. Partly because I don't use DEXA scans, but it's the preoperative X-ray, it's the demographics, it's a lot of factors I think that we can chat through a little bit, but I'm a little bit more conservative on that. So elderly females, I mean, I'm not at least with some of the implants I'd used before, not doing cementless. Now we have some new techniques and implants. We have a stemmable tibia, things of that. I think those are things that may broaden that a little bit, but I do think we, in general, need to be conservative about how we look at fixation. I tend to prep it before or understand and pick for that case prior to the case, so we have all the equipment ready to go. But however, it's rare that I switch intraoperatively, but it might be sort of a middle-aged female that I thought we were doing cementless that we switch out, but it's, sort of try to plan that ahead of the case.
Yeah, I want to push a little bit on something you just said and ask maybe Khalid or some to comment. What is this concept that we're talking about stems and related to cementless fixation? The idea of stems related to cementless fixation.
So you want early fixation, right? Early stability of the implant, so you can have great osseointegration. And I think the idea is that if you have a longer stem, you have stability achieved at the cut surface because you have something driven down into the metaphysis. I think talking about bone quality earlier, I do think that the osteopenic bone is concerning, and I'll pivot to a cemented knee at that point. But I also think the hard sclerotic bone is just as concerning to me. When you have that, eburnated bone medially in a varus knee, I'm not sure if I'm going to get great fixation with cement or cementless at that point. And I just wanted to bring that up for discussion or comment that I may pivot away from using cementless tray if that medial side is just polished bone. At least there I know I can score it and cement into scored bone versus will I really get ingrowth with that bone.
Any other comments on the technology that's being offered by various companies?
Yeah, I think Ira, just another comment along that, right? So we need the first, little while for the bone fixation to happen, right? For osseointegration to happen. Khalid, it sort of brought up a point. If you have sclerotic bone, you might take a little deeper cut. We also have patients that we're pushing them faster and faster, right? Outpatient surgery, younger males that are running around. And I do think certainly you need to that point of a little bit more robust initial fixation to have that to grow in so that we don't have fibrous fixation or other issues like that. I do think every company has their own sort of fixation surface. There's different porosity, there's different kind of printing surfaces. And then there's also sort of different isoelastic properties versus the bone that we're trying to grow it into. So it's not host factors alone, it's sort of activity as well. And then it's also the fixation technology. So.
Yeah. Roshan,
it's Mike Langworthy. Can I?
Oh, Mike. Yeah, I was just going to call on you. Glad you. Yeah, where's your face, man? Wait a second.
Okay. Yeah, I'm in the dark here. All right. So, question for you, gents. I'm a chairman in a program. We got a couple Makos. I had some surgeons doing some press fits, more expensive prosthesis. They've actually stopped doing them because of this. There was stiffness associated with the use, and when we tracked this down, there was some. It seems to be some misdirection of proteins that code for agricon and collagen, and they were certainly getting a higher propensity of stiffness in the press fit knees. The second thing we saw were, as the gentleman from Texas mentioned, you throw this in a guy that's 285 pounds and you immediately weight bear them. If there's more than 1/10 of a millimeter of micromotion, they are not going to get biologic fixation. And it seems that everyone's protocol for this is immediate weight bearing and aggressive mobilization. Except in my hands, if I use a press fit, I actually put them touchdown weight bearing for about 45 days. So the osteocytes have a chance to make adequate proteoglycans and collagen to adhere to the prosthesis. So any comments about the rehab in these heavy individuals, no matter what the prosthesis is? And two, are you seeing stiffness in the constructs that you're doing week in and week out?
Dare I speak?
Oh, yeah, Stan Lognicker. Introduce yourself and let's hear you.
Well, I've got about 6,500 bone and growth total knees to my credit. I started over 30 years ago. What I would tell you is that most people are trying to use cemented protocols to take with these people. The original protocols we had was 50% weight bearing for 3 weeks, then a gradual progression to weight bearing at 6 weeks. And that gave us great results. And I still use that protocol to this day. That being said, it doesn't matter whether you have screws or stems, as long as you have stable fixation. When that knee rolls back, it does not cause anterior liftoff. You're going to get bone and growth on the tibia. The femur's never been a problem. I've only had one failure on the femur in 6,500 knees, but I've had 2 failures on the tibia with people that went too quick.
Where are you practicing, Sam?
Jacksonville, Florida.
Excellent. Excellent. And so let's have some
I
comments.
have pushed this company for bone and growth knees for 5 years.
Super. Super. Some other comments on getting stability, Roshan? Yeah.
Yeah, a couple of comments. Lots of stuff, lots of great stuff has been said so far. I would say I went from for technology, I went from a 2-pegged trabecular metal surface with the just magical surface to the changed over, keel with 4 spikes from the same company. And I think that was a move in the positive direction with getting initial stability. The keel really does help. That 4-peg, when there's any disruption of the flat surface, can have lucencies. And I've done way fewer than 6,000, way fewer, and I've had way more than 2 failures on the tibia. Maybe like 5 or 6, but more than I would want. And I think the in terms of protocols that in retrospectively I would have I think protecting their weight bearing for a short period of time would have been great. I just don't think that's feasible in this market or in this in the modern times. Nor is it necessary given the track record of these implants, of the more modern day implants. The question about stiffness is an important one. I have a partner who's on a early study, like early market study of a new press fit from a company that hasn't previously had a press fit. And he has had a tremendous rate of stiffness to the point where he stopped using it and switched companies. So I think there may be some technological variances there that factor in, and maybe with the implant design, certainly could just be individual surgeon technique. But that's a good thought. In my series, I did not have any, I didn't know any concern with stiffness. So I'm not sure that it's a universal. And then with the obesity and the pressure and the micromotion, I think the key is it doesn't piston. They get up and walk and it just pushes right down if it's going to push down at all, and then gets ingrowth where it is. So I have seen, even in cement, especially in cemented implants, RSA studies show about 1 millimeter of subsidence or migration over the course of its settling. Same thing with cementless. And so I'll see at that 1 year or 2 year follow-up, you just have a little bit more play in laxity in the knee.
Excellent.
Hey, Ira, can I add something?
Yeah, absolutely. More. I was just going to call on you. There we
Oh,
go.
wonderful. So, yeah, the stiffness is real.
Introduce yourself, young man.
More Mefta from NYU. We looked at about 500 of our press fit triathlons that were done with Mako, and we had almost 5 to 6 times more manipulation for those as compared to other cemented version of triathlon or other companies. And it might be related to either fusions or some form of technology related, too early weight bearing. We don't know, but it's definitely real.
Very interesting. Stanton, I just want to go back to say, have you seen some stiffness, or is it the protocol, or what do you think?
I don't think there's a problem with stiffness as long as you slow down, don't let that knee swell. If the knee gets swollen because they pressed too fast or you didn't get enough, you didn't keep ice on it and keep it calmed down, keep it elevated, then you're going to get stiffness because it stayed swollen and the collagen gets a chance to stick up. One thing I would like to point out that I heard earlier on was people talking about divots in the knee from a saw blade. My gosh, take your time, make a bone paste and put it into that defect. It'll fill that in and you will not have a problem with that being a hole in the knee. Bone's wonderful. If you give it a chance to heal, it will do so. And I'll bow out.
Can you speak more, or Colin, you mentioned this as well. What are your techniques for filling bone defects?
I will use, if I'm in the middle of something that has circumferential bone, I will use any kind of bone I can get that came from the patient, be it bone paste that I created by taking the back side of the tibia or femur and scraping off a bunch of stuff with a saw blade and sticking it in there, or cutting a piece of bone to fill that defect. I don't care. Bone will grow into that and become a biologic part of that knee. I've had no problem filling huge defects with the patient's own bone. I have not tried it with allografts.
Yeah, so I'll do the same thing. I'll use the back of the tibia, the cut portion, and use my normal saw blade and just scrape the back of it. You can make a good bone slurry with that. Dr. Hoffman talked about that too, like the bone slurry he would put everywhere.
Exactly.
In specific spots, different implants are different, as we've all probably felt in our hands. Not all press fits are the same. I'll use some names here. So the Attune press fit femur has a different feel as you try to seat that. The TM pads on the back of the Persona are different than the PPS coating on the same Persona implant. So you have to kind of know where these implants maybe get hung up. And I'll use the slurry where I worry about that sometimes. What else? And the ACL knees, right? A lot of these young patients we're talking about maybe had a previous ACL, and so you've got that tunnel. So there, I'll use my chamfer cuts and make almost like little matchsticks and try to fill it into some of those defects and cavitary tunnels to try to get some bone there.
Khalid, are you seeing any of this stiffness going on in your practice, or you just haven't noticed it?
No, I haven't. I've had patients that, come back and they're 6 months out, like Roshan said, and they're hurting. And you don't always see that with your cemented knees. And it makes you wonder, hey, is this fibrous? They just don't have that fixation. And then we all get our second opinions that we see from around town. Maybe they didn't have the right protocol. Maybe they were moved too early and you're seeing them a year later. And maybe it's part of that whole scar continuum and all that. Have I seen stiffness in my patients? I wouldn't say any more in my cemented versus cementless knees to answer that question.
Yeah, I'm going to give sorry, again, who's talking?
I was saying, Longnecker. To that, I run about a 10 to 15% ankylosis rate that I manipulate, which got me kicked out of one of the studies. But that's the norm in my area.
Interesting.
So once you manipulate them, they're back to normal.
I'm also going something you mentioned, Stanton, about swelling. This is a shameless promotion for JOEI.
Go for it.
This is a great article by Andy Wickline, who is a anti-swelling freak about knee replacements. He thinks we're moving patients too early. This article got 8,300
Bingo.
reviews. And I have a lot of cousins in Brooklyn, so it really explains that. But I'm wondering to some extent, maybe since these patients are younger and we're using cementless fixation, maybe we're being a little aggressive with PT too early. Is that an issue?
I absolutely agree with you. I will not let my physical therapist take my knees past 50 degrees while they're in the hospital. Well, now everybody's outpatient, so I've been out of the game for about 3 years now from sickness, but I would not let them do that, particularly with cemented knees, because you're going to cause that base plate to rock if you push that knee. So you can't let your therapist push for flexion. That being said, if you keep the swelling under control, they don't have a problem with motion for the most part.
Interesting. Some comments about I want to switch gears a little bit. Khalid, I'm gonna go straight for the gut here. What are you using now? What company are you using now? And why are you choosing them?
Yeah, so I'm using the United Press Fit knee because of that ability to add a stem. So if that bone is softer and I've committed to the cementless design, I want that initial fixation, and adding that stem gives me a lot of comfort.
Interesting. Some of the other faculty, alternate companies. Roshan, what are you using for your cement?
I use the Zimmer Persona for both cemented and cementless,
Oh, okay.
and have previously used the two peg version, and then more recently the OsseoTi with the keel.
I had started with the next gen monoblock, two peg tibia tantalum, kind of compression molded. I kind of like that isoelastic nature of the implant as well, and obviously has a great track record. We've published on that 10+ year data. And had not really moved into the spiked peg type construct from like a striker triathlon type design. But I'm now using the Persona modular two peg for cementless. And then also along with Khalid helped kind of look into kind of a peg plus a stemmable tibia, different fixation surfaces with United here. So kind of going through a different evolution, but fairly conservative and not kind of moved radically, the last 10+ years. Yeah.
You feel it's an exciting time of design right now, Atul?
Yeah, I mean, I think there was a question I think from Yara in the chat as well on fixation surfaces and tantalum versus additive manufacturing. I think it's we are sort of at the cusp as well. Now that we have additive manufacturing that was brought up before, we can start shaping the implants a little bit and kind of looking at more modern or third generation designs. I think that's intriguing. We have to be conservative though, right? We have to kind of go with tried and true kind of formulas. I think our technique is going to be ever important. Some of these painful knees that are stiff may not just be from the implant, may not just be from the activity, but it just may be from poor balancing, right, of the knee itself, and it kind of leads to that cycle of inflammation. So I think we have to kind of change variables slowly and kind of iteratively. I think that's going to be the question, despite a lot of that interest and excitement on the newer prostheses and techniques. So,
Colin, what's your preference?
So I started out with cemented knees on all my patients, and this was fresh out of fellowship. So cemented knees on everyone. I moved slowly to cementless knees on Mako patients because from fellowship, I believe that the only true Nirvana flat cut surface could be achieved by a robot. So that was that. And then at some of the sites, I tried cementless knees, the same striker cementless knees, using a manual saw blade, and that seemed to yield good results. And then finally, I moved on to the United cementless knee because of well, one case that failed. I don't know if I could show a case. Let me see if I can share.
Yeah, you can share a screen.
Yeah. Are you able to see this?
Yeah, we got it.
Okay, so we'll start up here. This is a 57-year-old male patient. So this was me pushing the boundaries of what I thought could be a cementless knee. So this, I guess this would be when not to do cementless knee. So anyway, this is a 57-year-old male patient, spends most of his day in a motorized wheelchair. He is on an IL-6 blocker, Actemra, for rheumatoid arthritis, rheumatoid factor positive, plus also psoriatic arthritis. So he had both of that. He has some evidence of clearly inflammatory arthritis, but also some evidence of osteophytes and osteoarthritis. So this is his patella view. This was the post-op. So this was done with navigation. This was not a robot case. This was a cementless fixation. This was the day of the surgery, obviously, portable. And this was what happened. So this is an interesting case. So this happened because I think he spent most of his day in that motorized wheelchair. He doesn't really walk too much. I had to maneuver the wheelchair out of the OR, in fact, on the day of the surgery. And I think, so this is an example of, number one, when you expand your indications for cementless knees, this is my hubris, I guess. You have to look at bone quality. It's not chronological age. It's not the DEXA scan, the osteoporosis. I think if you look at the femur, or excuse me, if you look at the cut surface of the bone and you can indent it with your fingernail, I think that may not be the best case for a cementless implant. If you put in your pins for the 4-in-1 cutting guide and they slide in, or if you can remove your trials with your fingers, that may not be the best case for cementless knees. So looking at this base plate, this is an example of the Stryker Tritanium 4-peg on the undersurface. I don't know if you can see this. Oh,
Yeah,
getting blurred out by my camera. Anyway, so this is a keel with 4 pegs with an additive manufactured undersurface. Anyway, this is a comparison. I'm sorry, pre and post. What this happened, and this was what he got in the end. Anyway, so with the United, for example, they have a stemmable press fit. So where this happened, if I had perhaps a slightly longer stem, they have a 12.5 by 35 little stubby you could add on, which is kind of what we do with obese patients, where you put on a 12 by 50 or a 14 by 50 stubby on the end of a persona or the universal tibial base plate for Stryker, and then you put cement around it for obese patients. If we had that with a cementless base plate, that this possibly could have been avoided. Although, with the quality of his bone, this may not have been the best case for a cementless implant. So that's what I'm trying to say.
interesting.
Yeah.
Right. Let's
Can I add to that stem
Yeah,
idea? So it's about prepping the stem as well. So if you're going to use a stemmable press fit implant, a technique that I think works well is not drilling and prepping for the stem to the size of the stem. So I like having a 1 millimeter press from a axial standpoint and a rotational standpoint. So the drill that comes with the set I use is 10 millimeters short. So you get that press of cancellous bone axially. And then I think it's a 12.5 millimeter stem. So the drill is like 11. And so you get a circumferential press as well. So something to think about. It's not all stems are going to be the same in all press fit designs, like the same way they're not in cementless designs or cemented designs. So just get to know your equipment and really put some thought into that part of it.
Khalid, do you drill those on forward or reverse to impact the peripheral bone?
Yeah, that's a great point. I drill them on forward, but my next one I'll drill in reverse. I like that reminder. That's great. That's a great
I've
point.
I've done reverse for a long time after some of the early issues I saw, and so I think it works nicely.
Yeah.
And then I switched to doing that on my cemented as well. Might as well keep all that bone right in there.
Yeah. And so I mean, this is Joey, it's open mic. So full disclosure, I just drill really to open the metaphysis. So I'm drilling like 5 millimeters and I'm punching in a stem that's almost 30, I think it's what, 35 millimeters long total construct. So I'm getting a ton of press there. I'm comfortable with that. I would say that don't put your tibia in 5 degrees in varus do that with the kinematic concept. So just think about that.
Oh, one other thing I wanted to add on. Pick your base plate that sits all the way to the edge, like the cortical edge. I think that may be helpful. In that case that I showed, so not all proximal tibiae are the shape of a kidney bean. Some of them are more the shape of an arrowhead, where you may reach the edges on the ML, but not on the AP. So if you sat it all the way anterior on the AP, you would have overhang anterolateral, anteromedial. But if you had it sit just nice with the ML, then the front of the base plate would be recessed behind the front edge of the cortical bone. Does that make sense? So I think picking the right base plate that covers the entire edge of the tibia is something that's worth looking into. If you didn't used to do that with cemented, I think it's all the more important with cementless. There's some systems like the one that I showed where you have a size up, size down by 1 for tibia to femur matching. So the femur would match one size bigger, one size smaller, and the same size for the tibia, but not anything bigger than that. So you're kind of bound by the size of the femur / tibia. So you have to mate them together. Whereas with some of the companies, you're free to choose your tibia size regardless of what the femur size is.
Interesting.
I would speak to that.
Yeah, go ahead, Steve. Stan, sorry.
I would be very careful in not oversizing a femur to match the tibia, because you're going to pay for that with ligaments getting impinged by the implant, and then you have a painful implant. I would much rather undersize the tibia to match the femur than to oversize the tibia.
Interesting. I want to, yeah, Roshan.
Oh, real quick, there's some really good future technologies coming out. Monogram Orthopedics is one where I think they're going to be able to give you a really nicely milled surface along the metaphysis of the tibia and really get to the edges of the cortical bone. So some of these problems may be solved in the near future.
Interesting. I want to just talk a little about systems. I have an argument with my joint surgeons at my hospital. They're using a striker system that the cementless is not the universal base plate. So if the poly needs to be exchanged, it needs to be removed because it can't take a TS implant. Are your stem tibia and that you're using now, are they able to be modified and to a more stable construct, or do you got to take it out and put a new tray in?
The United tray could take the constrained.
Okay.
Poly. I don't have I mean, I do a CR femur, so I'd have to take the femur off to use constrained poly. But yeah, I think it can.
Yeah, and the devil's in the details of the contract pricing, right? Every hospital is a little bit different, and your ASC is different than the mothership, so to speak. But for example, the United prosthesis as well, you open the box, you have the stubby, it's sort of built into the contract pricing or to that pricing. But again, it really depends on your hospital. So not only the insert fixation option, but also the kind of metadiaphyseal fixation option that Khalid nicely, kind of elegantly described in terms of drilling and prepping that metadiaphyseal area as well. So I think systems that incorporate that and have that flexibility right off the bat, that's a huge win for systems, trays, inventory, staffing techniques, all that kind of. You can just open one system. I think that's a huge advantage.
Yeah. Roshan, your feelings about systems? Well, I don't know as much about the Zimmer system.
Yeah, it takes all polys, and so,
Okay,
but
good.
we had one with a chronic MCL tear that I put in the press fit tibia, knowing we were going to come back for an MCL reconstruction, and then at that later stage went to a more constrained polyethylene after the tray had a chance to grow.
It's good. So what I'd like to do now, we're at 8:55. Time goes very fast. I'm going to ask each of the panelists to sum up a little bit. Take 2 or 3 minutes to say some takeaway messages for everyone who's listening and everyone who's going to listen to the YouTube video. We post all this on our YouTube channel and on Joey. Many of our videos get as many as 500 views, which is a lot in orthopedics, not a lot if you're Taylor Swift. So let's start. I'll start with Colin because that's who I'm looking at right now. So Colin, just a minute and a half, little takeaway messages for people.
I think so. Choose your patients wisely. I think so. With every new technique that you do, it evolves in your hands. So the way you do each step, the way you perform your exposure, the way you treat sclerotic bone, the way you address bone defects, the way you decide, hey, I'm not going to be able to use cementless, I have to move on to cemented. So all those things evolve in your hands, and I think you should start slow. So start slow with cementless. It's, don't jump in with every single patient. You might want to do like the first patient and go, how does this feel? Does this feel tight? Is this patient going to need a manipulation at 6 weeks? There are, incredible advantages. I think let me just add one or two more things. Like if you
Sure.
have a draining wound at 10 days, you don't necessarily only have to do a poly exchange. I've done full one stage, it's easy. Everything pops back out at 10 days. If you have a few other little tips and tricks that I picked up, if you have a varus knee and it's sclerotic medially, if you make a flush neutral cut, by the time you're done pounding the implant in, it's going to be in a little bit of valgus. So I cheat on the side of a little bit of varus because it pivots around the sclerotic surface and it ends up in neutral. The opposite is true for a valgus knee. So little things like that, it's by feel. It becomes an art form rather than just the science of the cementless knee. So get to know the bone. I think with cement, you're just putting it in. Cement solves all problems. Get to know the bone. Cementless knees allow you to own the bone in a different way. You're owning the inside of the bone. You're getting to know it like kinetic sand, like a sculpture. And I think with time you develop your own little finesses, little tips and tricks, and you understand the nuances of each patient, not just the standard male, strong, good bone patient, but even the osteoporotic patients where, a little bit more force just sinks the implant so much further. I think just get to know your technique, get to improve your techniques, and I think it evolves with you. So the cementless knee is still evolving, the technology is evolving, and so should you as the surgeon evolve with it in terms of your techniques.
Excellent. Roshan?
I would say think twice before press fitting a patella in case it has to come out, and be mindful of bone prep, reverse ream. I think some of the bone slurry things are a good idea, and don't be afraid to fill with cement in certain areas if you feel like you need the extra contact and early stability.
Excellent. Atul?
Yeah, I think it's implant indications and technique, and just, I think we've really talked a lot about each one, but just on the technique, if you cut that tibia and the four corners test, if your tray's rocking, you really have to figure that problem out then and there in the operating room in terms of getting that fixation. You want to be able to lift the whole, tibia up, so to speak, with the implant. That's going to last. That's already impacted there. The other ones, if we're compromising or not good in technique, you're going to have that fibrous pain. You're going to have other issues. So yeah, implant indications, and of course the technique, I think, is the most important here.
Excellent. Khalid, you want to bring us home?
Yeah, I don't want to. I echo everything that's been said. I would add with robotics, a lot of times we get caught on that screen and we're just chasing gaps. And you'll do whatever you want to do to get the perfect gaps. If you're going to do a press fit knee, you may want to look at your bone resections. Specifically with the triathlon, I see a lot of times aggressive flexion of that femoral component. You need that anterior cut to be nice and good. That real estate grows in really well. So sometimes not having a lot of flexion there is good. And same on the tibial side. So echo everything. Great panel, great comments. But think I wanted to add that also there.
All right. I'd also like to sum up thanking all the panel members. I really appreciate your time, effort. Special call outs to Yair Kissin for comment, Mike Langworthy, Mort Mefta, and Stanton. You win the award for absolute best open mic comments. So thank you so much for coming on board. All right. So with that, I'll say good night to everybody. And it was a great session.